Hi, everyone. Can we start the webinar now? Dr. Stana?
Yes.
Okay, I will start the webinar and then you can start to introduce our speaker.
Should my video be on for the introduction?
Yes, for the entire session, yes.
Thank you.
Okay, I will start the webinar and then you can start to introduce our speaker.
Okay, good evening, colleagues. I'm Dr. Suzette Stander, and I'm the president of the South African Society of Periodontology, Implantology, and Oral Medicine. On behalf of SASPIO, I would like to welcome everyone here who's made time in their schedule to attend tonight's webinar. First of all, I would like to thank our sponsors, SADA, as well as Colgate, for their collaboration to assist us in doing these webinars during Oral Health Month. Just a gentle reminder, next week we've got another webinar for Oral Health Month, and our esteemed speaker will be Dr. Bradley Bredenkamp. He will be speaking on periodontal plastic surgery, why do it? Now, just a few housekeeping rules before I present our esteemed speaker for the evening. Once I've presented her, we will be taking questions after the lecture, and you are welcome to post your questions in the Q&A session. I would also, before we introduce our speaker, like to give Dr. Inalbana an opportunity just to say a few words as a sponsor for this evening. Thank you, Dr. Bana.
Good evening, everyone, and a very warm welcome. I'm Dr. Hinalbana, the Scientific Affairs Manager at Colgate, and it's particularly special to have you join us today during Oral Health Month. So I think this month really highlights our shared mission, making this collaboration with both SADA and SASPIO all the more meaningful. So our sincere thank you to both of them for their partnership. And a special thank you to Dr. Fourie for taking the time to prepare and present tonight. So at Colgate, we are really committed to supporting your professional growth and working with you to advance oral health in South Africa. And we hope that through these educational initiatives, we are able to take a step closer towards this goal. So before we hand over to Dr. Fourie, we just want to kick this evening off with a short video on Colgate Total. Thank you.
Prevention is power. Colgate Total's new prevention technology fights dental plaque, the root cause of many common oral health issues, helping stop those problems before they start. To fight dental plaque, many formulas use stannous fluoride. Powerful but highly unstable, it can degrade quickly, reducing the toothpaste's effectiveness over time. Unlike others, Colgate Total's patented technology stabilizes stannous fluoride using a novel combination of two known ingredients for three key benefits. 1. High bioavailable level of the stannous active. 2. Long-lasting efficacy. And 3. Enables customized formulas through sensory science for specific needs. Colgate Total's new prevention technology. Preventative, powerful, and patented science that helps fight the root cause of many oral health problems.
Thank you, Dr. Bana, and thank you for sharing the video of the new Colgate product with us. Then it is my great honor tonight to introduce our esteemed speaker, Dr. Jeanine Fourie, and the topic for tonight will be common oral lesions encountered in daily practice. So I'm quite keen to listen in this interesting lecture that she took so much time to prepare for us. So Dr. Jeanine Fourie, she's a specialist in periodontics and oral medicine at the University of Pretoria, where she serves in the Department of Periodontics and Oral Medicine. She earned her undergraduate dental degree in 2002, followed by her postgraduate diplomas in periodontology and odontology, as well as her MSc. And in 2012, she was awarded the MCHD in periodontics and oral medicine with distinction. Well done. Dr. Fourie has a special interest in oral medicine, which led her to establish a private practice dedicated to the diagnosis and management of oral mucosal diseases. She continues to provide evidence-based, patient-centered care at the University of Pretoria's Oral and Dental Hospital. And in addition to her clinical work, she's actively involved in undergraduate and postgraduate education, and she has a strong focus still on research in the field of oral medicine. Dr. Fourie, it is SASPIO's great honor to introduce you to our forum, and thank you. We're looking forward to your lecture.
Thank you, Dr. Stander. Good evening and welcome from my side as well. And thank you for joining me in this conversation tonight. I hope that I will share some meaningful insights with you regarding the 10 most commonly encountered oral mucosal diseases in clinical practice. But I wish to quickly perform a poll from you. If you can please comment in the chat function and name those conditions that you see most commonly in clinical practice. I'm just going to give a minute for this. If you can please populate the chat and share with us what is it that you see most commonly. I hope to cover those diseases. I'm not seeing any comments yet. So it's possible that you guys aren't seeing that much oral medicine in clinical practice. So I'm going to carry on and share with you my screen, and let's move through this presentation. Right, I just quickly want to move a couple of things out of the way. Right. Okay, so luckily I performed a research study at the Oral Medicine Clinic. And during this study, we looked at which are the conditions that we see most commonly in clinical practice. And for some or other reason, my presentation is not moving along, but what we saw there was that in the public oral medicine clinic, we saw patients with Candida, Leukoplakia, oral Lichen planus, pyogenic granulomas, and oral squamous cell carcinomas the most frequently. But I think our results are a little bit biased by the fact that we are a tertiary referral center. So of course, we would see oral squamous cell carcinomas much more frequently than you would probably encounter in clinical practice. In fact, it is estimated that a dentist will see one case of a squamous cell carcinoma in 20 years of clinical practice. We also saw an abundance of pyogenic granulomas that I didn't see in private practice. And this is most likely because every single mucosal pathology is managed not by us. There's the maxillofacial and oral surgery department as well, but the students can't necessarily remove these lesions themselves. And that's why these get referred to us. But in my private practice, I saw oral Lichen planus the most commonly by far, followed by Candida, Xerostomia, burning mouth syndrome, and recurrent Aphthous stomatitis. So these are the ones that we are going to focus on tonight. Now, oral Lichen planus, I must admit, I get very elegant referrals of this condition. I think that dentists do a good job in recognizing the disease. But the term oral Lichen planus never meant much to me, even though now it is my bread and butter disease. But the term actually comes from Latin, and it means lichen is small bumps, and planus means flattened. But lichen also refers to a moss-like creeping covering found upon rocks. So this really visualizes the clinical appearance of the disease. And subsequently, I now have consolidated that image for myself. To make a diagnosis of oral Lichen planus, we are supposed to exclude oral lichenoid reactions. So we're not going to focus on that tonight. Those oral lichenoid reactions can occur in response to drugs as well as contact allergens, but then you need to show a direct temporal relationship or topographical relationship between these local etiological agents and the disease. But arguably, that's sometimes much easier said than done.
Dr. Fourie, sorry for
Yes.
barging in your lecture, My face, I think if you can just move that from your screen, it's sharing over the lecture.
Ah, awesome. So I can get rid of this altogether.
Yes. And then the
Um,
other thing is I see our chat functionality is disabled. If it's
Okay.
possible, please, if SADA, I've asked Marlies if they can just activate the chat functionality so that we can please get feedback with Dr. Fourie's question
Okay.
that she
So
asked
it
in.
wasn't me.
No, it wasn't you,
That's a
Dr.
relief.
Fourie.
Let me just
Just
see if I can
close
get
there.
rid of this. Yes, better.
Fantastic. Thank you.
Awesome. Thank you so much for highlighting that issue for me. Okay, so moving along, I would like to explain to you a little bit of what lichen planus entails. So lichen planus is essentially a T-cytotoxic lymphocyte attack against the epithelium, directed indigenously. In other words, it doesn't have a particular target. It's just the epithelium in general, according to our current understanding. And the epithelium then responds to this attack by either buttressing itself so that it increases in thickness, or surface keratinization, and that results in the white reticular plaques. But the other possibility is that the attack is just so intense that it subsequently results in erosions and ulcers. Now, these variations of the disease always beg people to classify it as reticular, erosive, ulcerative, and I'm not such a big fan of doing so, and I know that very knowledgeable people will disagree with me, but I just feel that any one of these varieties can be present at any given moment in time, and we need that white reticular plaque actually to make a diagnosis of oral lichen planus. It's a diagnostic criterion, and we don't need to dedicate or assign a patient to a diagnosis because it will fluctuate over time. The patient isn't destined to have this particular variety indefinitely. And that brings us to who it predominantly affects. And as with many of the immune-mediated diseases, we generally consider that women are much more frequently affected. And yet there was a recent systematic review that demonstrated that there's actually an equal prevalence between men and women. However, it's very likely that women are just more likely to seek help. They've got greater help-seeking behavior probably than men. And it occurs most commonly between the ages of 40 to 60 years of age. And it affects classically, bilaterally, symmetrically, the buccal mucosa and lateral borders of the tongue. It can also, not in isolation, but in combination, affect the floor of the mouth, the dorsal surface of the tongue, the palate, the gingiva, where it appears as a desquamative gingivitis, as well as the lips. The reason why this develops, though, is unclear, and there are a couple of theories. Not any single one explains the reason sufficiently, and something like hepatitis C virus infection had garnered a lot of attention, and there's a good mechanistic explanation for its role, but it seems to have a geographic limitation that it is not universally extrapolated across the globe. Another argument that has been put forth is that stress dysregulates the immune system, and we definitely experience, patients definitely experience worsening of their disease around stressful life events. And yet, by itself, it's probably not sufficient to cause this disease. Now, oral lichen planus is considered by the WHO as an oral potentially malignant disease, and I'm going to elaborate on a more classic variety of oral potentially malignant diseases a little bit later. But there's a lot of controversy around this potential malignant nature of the disease, but at the moment, it is accepted that there's about a 1% malignant transformation rate of this condition. And that is why annual monitoring is so essential for this these patients, and patients should be made aware of this potential risk associated with the disease. And this is true both for oral lichen planus as well as for the oral lichenoid lesions. Now, those are conditions that don't fulfill all of the strict diagnostic criteria, either histologically or clinically. But suffice to say, this group of diseases does have a malignant transformation. And while I've mentioned the 1% malignant transformation rate, Gonzalez-Moles argues that it's probably much more if we use more realistic inclusion criteria. I think we are unnecessarily biased against oral lichen planus in this regard, and that updates are necessary. The explanation for why this happens is on two levels. One, mechanistically, we understand that those sites of inflammation can result in genetic alterations that result in cancer. And we also see this in other chronic inflammatory diseases. But another explanation would be that those ulcerative and erosive sites give greater access to common carcinogens such as cigarette smoking and alcohol. And therefore, these associated factors should be limited and exposures thereof. And it also speaks to reason then that if we successfully manage our patients and we eliminate these erosions and ulcers, we should hopefully be able to minimize risk even further. Oral lichen planus behaves as a chronic, remitting, and relapsing disease. Now, by chronic, I don't mean to imply that it isn't manageable. Yes, we can't cure it, but we can definitely manage the patient's symptoms in order to restore their oral health-related quality of life. In other words, they will be able to reinstitute plaque control, eat more or less what they want to, and have social interactions. And in managing these patients, there's a condition or a phenomenon called the Kupner phenomenon. It just says that lichen planus doesn't like to be annoyed. So we wish to remove all mechanical and chemical irritants that the patient could be exposed to, just to, I always explain to patients, make the immune system go to sleep and lose interest in the oral environment. So that is the first strategy that we employ. And then the gold standard in treatment of oral lichen planus is with topical glucocorticosteroids. I'm going to share an algorithm with you guys via email that SADA said that they will distribute, and that just clarifies the potential for topical glucocorticosteroids to be used in oral medicine. And even though I say it's the gold standard, a Cochrane review said, but we don't actually have spectacular evidence. I think it becomes increasingly difficult to garner that evidence because we can't leave patients without treatment. So now it has been solidified in our treatment armamentarium, and we see that it works. So in 99% of cases, that would be more than sufficient treatment. And in other instances, the patient may experience asymptomatic stages of the disease that does not require any treatment whatsoever. In the exception of cases, we may have to use a systemic corticosteroid just to gain control of the disease a little bit more quickly. But if the patient's disease is of such a nature that these prescriptions tend to be prescribed at frequent intervals to manage the patient's symptoms, then we will have to start looking at steroid-sparing drugs such as methotrexate and dapsone. But yeah, I think I know of 2 patients in which that would have been a requirement. I also know of a patient that was managed with methotrexate unsuccessfully, and topical glucocorticosteroids was actually sufficient. So that just paints the complexity of managing the disease. An alternative to a topical glucocorticosteroid would be a calcineurin inhibitor like tacrolimus. It wouldn't be my first choice because it is a little bit costly, and it also tends to sting the mucosa upon application. But it's worth considering in those patients that you fail to achieve success with a topical glucocorticosteroid with. The alternative that has also been proposed are the retinoids. that doesn't make a lot of sense to me because the retinoids only succeed in eliminating the white plaques, and the white plaques aren't sensitive or symptomatic. So the use of the retinoids is on top of my list of priorities. And the biggest consequence of our management is that we can encounter candidal overgrowth because of the local immune suppression, but also because oral lichen planus creates these surface irregularities that Candida proliferates in. And luckily, that brings me then to Candida. It was one of the shared, highly prevalent conditions, both in public practice and private practice. The essential message with Candida is that it is a commensal organism. It happily lives with us without causing any harm. And it's only when the organism gets a little bit of a growth advantage because local or systemic factors favors the growth of Candida. And then we will encounter clinical evidence of the disease, and these are separated into white plaques that are either removable or not, or alternatively, all of the red varieties that can appear in the midline tongue dorsum as a kissing lesion against the palate, underneath the denture, in the corners of the lips, as well as more generalized and diffuse in the patient following antibiotic administration. So realizing that it is a disease of the diseased, it asks of us to identify the underlying reason for why Candida got this growth advantage. And this may range from significant factors such as HIV, and it used to be an indicator of HIV infection. So it triggered the diagnosis of HIV, but nowadays it has rather become a marker of treatment failure. But it can also be as simple as a patient that lacks adequate saliva to defend them against Candida. So we have to look at all of these possibilities, and it's very important that the underlying reason be addressed, because otherwise our treatment will eventually fail and we will struggle with recurrences. And in situations where you can't change that underlying reason, we can rely on something like chlorhexidine as a mouth rinse, delivered infrequently, that will suppress the growth of Candida. I quickly mentioned all of these clinical varieties, and I want to emphasize that because that is the guide by which we make a diagnosis. It's seldom necessary for us to perform special investigations, with the exception of hyperplastic Candida, because that white plaque can resemble an oral leukoplakia. But there's yet another nice article by Manfredi, and he discusses this precarious point in time at which the commensal organism becomes a pathogen. And the histopathologist will argue that it is when we demonstrate the transition from a spore to a hyphae, that means it can penetrate into the tissues. Alternatively, the microbiologist will argue, but it depends on the load of the organism that colonizes the host, which implies that the host has lost control over the growth of Candida. But Manfredi argues that this is a continuous pendulum of homeostatic balance that can shift. And these laboratory investigations should not be the sole determinant of our treatment, and that we should rely on clinical evaluation. And accordingly, because these predisposing factors needs to be addressed, our treatment should be aimed both towards the organism as well as the host. So change whatever factors are responsible or contribute within the host, and then when you turn your attention toward the organism, you're going to start first with topical antifungals such as nystatin, miconazole, and clotrimazole. It is with the exception of oropharyngeal involvement, where you won't have access of the topical antifungals to that involved surface, or alternatively with hyperplastic Candida, that you will be obligated to choose fluconazole or itraconazole. Luckily, both miconazole and clotrimazole are ideally suited to manage angular colitis because they have both simultaneously anti-Staphylococcus aureus and anti-Candida properties. So it will be sufficient dual treatment. And I know that many people favor the use of a topical glucocorticosteroid in this scenario as well to address the inflammatory involvement, but that will naturally regress anyway with successful antifungal therapy. And sometimes I think it just confuses the issue a little bit. Before we discuss xerostomia, I just need a sip of water. Now, xerostomia is defined as the subjective sensation of a dry mouth. Subjective implying that you don't need to objectively demonstrate and argue with the patient that whether there's evidence of a dry mouth or not. It can simply be that this patient experiences less saliva than they are accustomed to, or maybe the ingredients have changed and the patient doesn't experience the same degree of lubrication. Yet we have a couple of nice inventories that we can use, the Dutch and the Fox questionnaire, that will validate the patient's experience, and those do tend to correspond well with objective salivary gland dysfunction. If we assess the patient clinically, objectively, there will be a fair number of factors to consider that will substantiate diminished salivary gland output. And those would be that you fail to milk saliva from the major salivary glands, that the mirror sticks to the mucosa, that lipstick sticks to the teeth, that the tongue sticks to the palate as the patient tries to speak to you, that there's atrophy of the tongue papilla, there's no pooling of saliva in the floor of the mouth, maybe there are frothy deposits of saliva everywhere, a high risk of incisal and cervical caries where you wouldn't expect to find it, and then, of course, canital overgrowth as well. The history taking is really essential to determine what the underlying cause of the salivary gland dysfunction or symptom of xerostomia can be. And it should start with lifestyle factors that can play a significant role. And that would be things as silly as being dehydrated, not drinking enough water, drinking too much coffee or alcohol, cigarette smoking. Yes, so a multitude of lifestyle factors can be associated. And then we start to explore a little bit further along diseases that can influence salivary gland function. And that would include things like HIV, uncontrolled diabetes mellitus, anxiety, depression, sarcoidosis, Sjogren's disease, as well as all of the rheumatological diseases that results in secondary Sjogren's disease. But the management of these diseases could equally impact the symptom of xerostomia. There are a couple of known culprit medications like the antihypertensives, especially the diuretics, antihistamines, antidepressants, anxiolytics, the anticholinergic drugs that manage a hyperactive bladder, for instance, in the elderly. So these are nice mechanistic reasons for why salivary gland function would be impaired. But beyond that, the mere fact that the patient takes 2 or more drugs will already result in a major impact. And when we get to the management of this problem, there's another infographic that I've asked Sarah to share with you, that you can share with your patients about how to approach this situation. And always change whatever you can, but admittedly, there are often unchangeable or unalterable diseases or medications at play, and therefore we simply revert to the protection of the oral mucosa against Candida and the dentition against caries, and then the strategy to replace by ensuring adequate hydration with optimal fluid intake, lubricating the oral cavity with olive oil, and maybe substituting saliva with artificial saliva substitutes. In a patient whose dentition and temporomandibular joint allows, you can propose the use of sugar-free chewing gum, for instance, but that is as far as our stimulating properties or avenues extend, because we don't have drugs such as pilocarpine or cevimeline. These are cholinergic drugs that would ideally stimulate saliva gland function. Now, burning mouth syndrome is probably the most misunderstood, underappreciated, and overdiagnosed condition in dentistry. We just have to realize that burning is a common sensation of many visible oral mucosal diseases, but the diagnosis of burning mouth syndrome requires us to exclude any visible reason for why the patient would have this symptom. So if you inspect the oral cavity, there should be no mucosal abnormality that can serve as an explanation for burning. In addition, we should also exclude any underlying systemic diseases like nutritional deficiencies, a hyperactive thyroid, diabetes mellitus, that could contribute to a burning sensation even in the absence of any clinical abnormality. And there are also drugs that have the potential, now ACE inhibitors, for instance, to cause such a burning sensation. So after having excluded any logical reason for why the patient could have this symptom, the history that the patient reveals to you will be very illustrative in making a final diagnosis. There are a couple of key complaints of features of this burning sensation that the patient will mention. The first is that this sensation is likened to having scalded your mouth with warm liquid. So that is the nature of the sensation that they experience, and this is usually absent upon waking in the morning, progressively worsens during the day, and is absent at nighttime. It doesn't interfere with sleep. And the most remarkable feature is that whenever the patient eats or drinks almost anything, there will be an absence of symptoms. There's a very logical explanation for this, and this is based on the pathogenesis of the disease. And admittedly, we don't know what the etiology is. There's also, of course, a large psychological and psychosocial component proposed to the etiology of the disease, but it's hardly possible for us as dental clinicians to weigh in on the psychological makeup of many of our patients. That will need much greater investigation. But the pathogenesis is nicely explained. It is said that it is a trigeminal small fiber neuropathy. So there's changes in the densities of the peripheral nerve endings as well as the receptors, the transient receptor potential vanilloid receptors. And there can also be dysfunction of the chorda tympani nerve that is normally supposed to suppress pain perception by the lingual nerve. And that starts to explain the simultaneous complaint that the patient raises of an altered taste that they experience. The third part of the syndromic classification of burning mouth syndrome is that the patient may also complain of a dry mouth, and usually there's no objective evidence thereof. So I sometimes say that it's all one big lie that the patients are being told by their nervous system, that there's burning, that there's dryness, and there's a change in taste. These peripheral pathologies, yes, there are central pathologies associated with the disease as well, but the peripheral ones, they respond really well to topical clonazepam therapy. That is a benzodiazepine with GABAergic effects, and there are surface, local oral surface GABA receptors present in the oral cavity. So the use of clonazepam as a mouth rinse will completely numb the transient receptor potential vanilloid receptors, as well as resulting in the impact on the GABA receptors. Other alternatives that you can consider maybe would be alpha-lipoic acid, which is an antioxidant with neuroprotective properties. Capsaicin has been put forward as an alternative, and something that I've used, and it's a good alternative to topical clonazepam therapy, and I've also had some success with the use of laser biostimulation using a diode. It's a good it's something to consider if you fail success with clonazepam. I'm sure if you don't have any patients with recurrent Aphthous stomatitis, you may be one of the sad dentists who experience recurrent Aphthous stomatitis. Our patients often mistake this as fever blisters, and it is the most common cause of oral ulcers. Among all of the oral ulcerative diseases, it has the most significant impact on the oral health-related quality of life of our patients. And therefore, despite its common nature, it really should not be dismissed. There are a lot of different triggers proposed, and it may be different things for different people. And in many instances, we may not be able to identify this trigger, nor will we be able to eliminate it. Sorry, I just quickly want to go back and look at the classification of the different types of recurrent Aphthous stomatitis. You are very familiar with the classification between minor, major, and herpetiform. But we should also consider the way in which it behaves as simplex or complex. In the simplex presentation of the disease, it's like the garden variety. The patient experiences infrequent recurrences around stressful periods, whereas the patient with complex disease will have almost persistent disease experience, meaning that the one ulcer heals as the other one starts to appear. And there may be multiple ulcers, and other mucosal surfaces may also be affected. Regarding the triggers, we mentioned it may be different things for different people. Sodium lauryl sulfate, that soapy ingredient in toothpaste, has often been blamed, but it looks from the literature as if it rather acts as an aggravating than an eliciting factor. So in after-free periods, your patient may happily use a soapy toothpaste, but when an ulcer develops, it may be best to switch to a soap-free alternative. It's especially for those patients with complex disease presentations that we are compelled to look for a reason why the patient has the disease. In this patient, the patient presented with HIV shortly before the onset of these ulcers. So it looks completely indistinct from a recurrent Aphthous stomatitis. It behaves a little bit differently, but fundamentally, it's still an Aphthous ulcer. Other conditions that may be associated are nutritional deficiencies, independent or subsequent to gastrointestinal diseases. There's also a couple of inflammatory diseases that are classically associated with Aphthous, and these are Behçet's and MAGIC and FAPA and Sweet syndrome. And there's also medications such as the angiotensin receptor blockers that could be responsible for Aphthous ulcers. We usually don't use a special investigation to make a diagnosis of the ulcer, but we would use a special investigation to make a diagnosis of the underlying reason. So that would be the best explanation. Our treatment is yet again with topical glucocorticosteroids in some shape or form, depending on the extent and the distribution of the lesions. For oropharyngeal involvement, for instance, with the major aphthous, you can think about using something like a steroid inhaler because an ointment won't reach and neither will a mouth rinse. In certain instances, we may even look towards using systemic glucocorticosteroids because of the intensity of the attack and the frequency of recurrences, because the topical treatments won't stop a new ulcer from developing. But yet again, if these uses becomes too frequent, we prefer to look at steroid-sparing drugs such as colchicine or dapsone. But other topical alternatives to consider instead of glucocorticosteroids are doxycycline, and in this instance, you can repurpose it into a mouth rinse. So you can dissolve the tablet into a little bit of water and create a mouth rinse from it. Or alternatively, study had demonstrated how you can mix it with denture adhesive and locally apply it over that ulcer. But here we aren't relying on the antimicrobial properties of the drug. It's rather because it inhibits matrix metalloproteinases. And one last alternative to consider is yet again laser biostimulation. Which brings us to oral leukoplakia, which is the quintessential oral potentially malignant disease. The oral potentially malignant diseases are a group of lesions and diseases with the potential of malignant transformation. Emphasizing potential because the patient isn't destined to develop an oral squamous cell carcinoma, and as a disorder, recognizing it isn't necessarily the site of the leukoplakia that may undergo malignant transformation, but that the entire oral cavity is at risk because it has been exposed to a carcinogen. The definition of a leukoplakia, as currently proposed by the WHO Working Group, is that it is a white, predominantly white plaque of questionable risk, having excluded other known diseases or disorders that carry no increased risk for cancer. The diagnosis therefore rests on the recognition and exclusion of other white plaques and should be considered as a diagnostic term and not as a descriptive term. So don't use it to describe the white plaques that you will see in oral lichen planus, for instance. As I said, it's a diagnosis of exclusion, and therefore you have to systematically consider all of the other white plaques that you know of in the oral cavity, and then come to the conclusion, oh, it cannot be anything else. So part of the diagnostic criteria that should be met is that it shouldn't be removable if you wipe it off with a piece of gauze. The borders are usually well defined. There may be a little bit of a red speckled or nodular or verrucous surface associated with the non-homogeneous leukoplakias, and there shouldn't be any evidence of friction or trauma. And if you think a sharp tooth cusp is responsible for the frictional trauma, then you should relieve that sharp tooth cusp and the lesion should stay. And neither should it disappear when stretching, as leukoedema or tobacco pouch keratosis would do. So now, once you've reached that clinical diagnosis, it becomes imperative to perform an incisional biopsy to reach a final diagnosis. The histopathologist will again exclude other possibilities to come to the conclusion that it is in keeping with a leukoplakia. And they will also mention whether there's dysplasia present or not, and grade the dysplasia so that an adequate risk determination can be made. Now, obviously, we want to take a biopsy of the most representative site. Most representative meaning we have to select that site with the worst degree of dysplasia because that is what's going to guide future treatment. And on clinical grounds, you can look at that site that includes a little bit of red, verrucous or nodular surfaces, but we can also use tools like Tolidine Blue or the Valscope because they pick up the molecular and metabolic changes associated with dysplasia. but they are not specific for dysplasia. Other conditions can also result in taurodin blue uptake and loss of fluorescence. The management of the patient requires a holistic review of risk factors that can be modified and minimizing exposure to known carcinogens. At the moment, management is still guided by the risk determination from grading the dysplasia. The moderate and severe degrees of dysplasia requires excision of the lesions, whereas mild and non-dysplastic sites may be monitored. Yes, there's still arguments ongoing about this as well. So surgery remains the main treatment modality. As an alternative, chemotherapeutic agents have also been explored, like bleomycin, 5-FU, lycopene, the retinoids again, the non-steroidal anti-inflammatories, and they are able to institute a clinical and histological cure. And regardless, it doesn't change the malignant transformation risk of these lesions. So the moral of the story is, but that is true, unfortunately, for the surgical resections as well, that the patient still remains an at-risk patient, not only of that site, but of the entire oral cavity. And that is why continued surveillance and intensive monitoring is required for the lifetime of this patient, essentially. Luckily, geographic tongues are a little bit of an easier conversation to be had. And it's interesting for me how we misunderstood this condition when we were being educated as dentists. We were always taught that it is because of an allergic reaction. So maybe that immune-mediated pathogenesis signifies an allergic reaction to the host itself. But yet, yes, this is a common condition that our patients often self-diagnose based on the clinical features that are so characteristic, that we have loss of the filiform papilla, a white circinate border surrounding this loss of filiform papilla. Maybe it is just the greater emphasis that is now placed on the remaining filiform papilla, but there's also a band of erythema that migrates across the dorsal surface of the tongue, but it could also affect other mucosal surfaces. The pathogenesis corresponds very well to that of psoriasis in the fact that neutrophils migrate into the epithelium and create microabscesses, and that is what is responsible for the loss of filiform papilla. And in these sites, the patients may experience some sensitivity upon eating spicy foods, acidic foods, but generally they usually more complain about the appearance than about the sensation. And that was my first experience of using topical glucocorticosteroids yet again to manage this disease, because a young man came to me complaining about the appearance of his tongue, and I said, I'm fairly certain that I can fix the symptoms, but I'm not sure if I'm going to change the appearance. But yet it did. So the use of topical glucocorticosteroids are effective both in managing the symptoms as well as the clinical appearance. Now, I specifically present to you a picture of a pyogenic granuloma in a fairly unusual location. I feel that we grew up thinking that pyogenic granulomas occur exclusively next to a tooth. And of course, that is the most prevalent location of these lesions. And that is simply because the etiology is usually situated in proximity to a tooth, because we have calculus subgingivally lacerating into the fragile gingival sulcular epithelium, and the vascular plexus underneath responds over-enthusiastically with the formation of an abundance of granulation tissue, which fails to be covered completely by epithelium, so it results in that purulent appearance of the surface of the lesion. But over time, this tends to mature And we find that the blood vessels diminish in size and number and becomes replaced with collagen. And that allows for the intact epithelial covering that we see in a fibrous epulis and a fibroepithelial polyp. So fundamentally, these conditions are reactive lesions, meaning that they occur in response to something which places the responsibility on us to remove the cause. Of course, that fibroepithelial polyp, it's hard to imagine how it got there. It probably got there before the dentition was lost. But it's imperative to remove that underlying etiology. And when the lesions are excised, it has to be excised down to the periosteum, which gave rise to the lesion, and remove all of the granulation tissue associated with the root of the problem. This brings us to recurrent herpes labialis. And we know that we encounter this virus in childhood, usually asymptomatically, and then it becomes dormant within the trigeminal ganglion. When it reactivates and it starts to proliferate and travels down the trigeminal nerve, that surface of the lip to which it is heading may start to experience a little bit of a prodrome of a tingling and a burning sensation. That prodrome that I just explained to you really creates the ideal opportunity for us to manage it with topical nucleoside analog drugs such as acyclovir and penciclovir. It's usually a very limited use once the blister has appeared, because by that time viral proliferation has ceased, and these drugs are essentially just anti-proliferating. It does not kill the virus. We rely on the host to clear that infection for us. There's been a recent network meta-analysis that said that topical glucocorticosteroids employed with the topical antiviral therapy has the added benefit of minimizing the duration and the symptoms of the disease. So it is worth exploring to add a topical glucocorticosteroid also then in this setting. So topical therapy may suffice for the patient with infrequent recurrences, but for a patient that experiences more than 6 recurrences a year or very disfiguring recurrences, it may be necessary to use systemic antiviral treatment prophylactically, either continuously or intermittently around high-risk exposures. And there's another infographic that I will share with you about the practical use of these drugs. But usually when I mention that we can use the nucleoside analog drugs systemically, people get concerned about the risk of antiviral resistance. But this is really an unnecessary controversy, because the virus that is situated within the trigeminal ganglion is not exposed to our antiviral treatment. It is only that portion of the virus that has left and is traveling down the trigeminal nerve. And that only being said in a patient with a very suppressed immune system who is unable to clear that viral infection. So now, after prolonged exposure and the inability to clear the infection, that virus can become resistant. But you haven't created a super mutant that is all of a sudden going to jump and spread like wildfire among the population. They lose their replicative potential as well as the potential to be transmitted. And now when the patient's immune system has recovered because they received a bone marrow transplant, for instance, now every subsequent reactivation is again going to be with a naive virgin population from the trigeminal ganglion. And the nucleoside analog drugs will yet again be successful in managing this problem. As I said, when the patient presents with a blister to you, the drugs won't be of any benefit. So here you have to rely on the physical destruction of the lesion. And you can do that either by lancing it and making sure that you suction all of the viral liquid, Or alternatively, you can use a diode laser. And when you use a diode laser, you will have the added benefit of a little bit of peripheral biostimulation that will speed up healing. And the diode lasers can also be used during the program that will create a little bit of an immune privileged site so that when the virus reaches the lip surface, it will be buttressed against creating those destructive effects. A mucocele is commonly encountered in children, especially because they are more likely to get a bump to the lip and then rupture the minor salivary gland duct or duct. And now you will have spillage of the mucin within the submucosa and the creation of a little bit of a pseudocyst that is fluctuant, filled with fluid, sometimes disappears only to reappear again. And what we usually do is we excise the entire pseudocyst-like cavity and try to get rid of any minor salivary glands in the vicinity or proximity that could be responsible for the mucocele. But other people have said you can use cryosurgery and laser surgery or micromarsupialization, in which you tie a silk ligature through the vesicle, and that should create a new draining orifice. But I've never been successful in executing this. And this brings me finally to some key takeaways. And the first one is that Candida does not give rise to oral ulcers, and accordingly, please do not prescribe antifungals for oral ulcers. Those fungal infections that are responsible for oral ulcers won't be you can't manage them with topical antifungals. You can't even manage them with fluconazole. So don't use antifungals for ulcers. The next one is that we mentioned doxycycline's use as an immune modulating drug. I never mentioned once that we should use antibiotics for the management of oral ulcers. And that is because the only reasons for oral mucosal ulcers that are caused by bacteria are syphilis, TB, actinomyces, and the necrotizing periodontal diseases that may extend into the mucosa. So my major take-home message is that you should please not prescribe amoxicillin and flagyl for your garden variety of oral ulcers. That prescription will only work for the necrotizing periodontal diseases. Next is that you may misdiagnose, and we have the privilege of obtaining a thorough history from our patients and also observing how the disease behaves. If your treatment does not work, or if you become unsure about what you're dealing with, please refer, call in for a consult, and get someone else's opinion. And maybe not on your horizon for this evening, but please don't suggest the use of immune boosters for the patient that struggles with an immune-mediated disease, because that will directly oppose the action of the topical glucocorticosteroids. Before I open for questions and comments, I would just like to deliver a quick advertisement regarding an upcoming short course that we are developing with enterprises at UP. This will be on the topic of the management of common maxillofacial and oral diseases. It will be fully online and self-paced. You can take as little time or up to a year to complete the course, and it will be fully CPD accredited. So please keep your eye on my LinkedIn account, and we will update you with advertisements come the beginning of 2026.
Thank you, Dr. Fourie. It was a really insightful lecture for this evening. I see we have a few questions that popped up. Maybe we can fire away with that, if that's all right.
Yes, of course.
Okay, so
And it's so difficult.
Okay, so the first is from an anonymous attendee that asked, is there a link between oral lichen planus and Aphthous ulcers? And is there some evidence that a surgical approach can cure either of the conditions? And then they say they've spoken to some specialists who have noted that after surgery or biopsy, the oral lichen planus underwent remission of the condition. So what can you comment on that?
Yeah, so from the literature, I would disagree with this. These are two separate disease entities with separate pathogenesis that drives the conditions. And I don't think that surgery is the ideal treatment modality for an immune-mediated disease, because you're not going to change the behavior of the immune system by eradicating an isolated lesion. So I don't think that would be in keeping with our current understanding, unfortunately.
Perfect. And then there's a question, Dr. Fourie, about if it's possible to please summarize the antifungal treatments for Candida again.
So the antifungal treatment for Candida, we should rely firstly and foremost on the topical antifungals with nystatin, miconazole, and clotrimazole. So admittedly, clotrimazole is a vaginal cream, so some people are reluctant to use it, but you can actually use it orally as well. So that is just to set the scene for the topical treatments that are available. And your choice among these treatments will rely on the specific scenario. So for instance, you have a patient with a denture-associated stomatitis, ideally suited to the use of miconazole, for instance, because you can use the denture as a vehicle to deliver the miconazole to the surface of the palate. Whereas in other scenarios, nystatin would probably suffice. The only exception that warrants the use of systemic antifungals like fluconazole would be when you have oropharyngeal involvement of the disease, because the topical treatments can't reach that far, as well as for the management of hyperplastic candidiasis. And that is as far as the antifungal therapies goes. Just be cautious about drug interactions, of course, with warfarin and miconazole. Despite its topical use, it can result in significant drug interactions.
Thank you, Dr. Fourie. Then we've got a question from Andries Kuman. She's asking, what is a typical topical corticosteroid to use for geographic tongue?
So I've asked Sarah to share with you an infographic regarding the different possibilities that are available to you, but I've turned basically towards the overall use in every scenario of betamethasone. That is what I teach the undergraduate students, because there are so many different varieties available, like fluocinolone and hydrocortisone and betamethasone and clobetasol. But if you become familiar with the use of betamethasone, you can tailor make it in terms of its formulation as well as its frequency of application to suit your purposes. So betamethasone is fairly potent. So if you select to use betamethasone as an ointment, which I think would be a fair assumption because you can nicely apply it over the surface of the tongue, then maybe as infrequent applications as twice daily would suffice. Whereas in a patient with more severe disease with oral lichen planus, you would require the application 4 times daily, for instance. So you can adjust the formulation and the frequency of betamethasone to your treatment needs.
Okay.
I hope that helps.
Thank you, Dr. Fourie. Then we've got again another anonymous attendee that wants to know about the topical cortisone go-tos brand-wise. I think you've answered that.
I think I basically touched on that. And yes, I'm going to share that infographic with everybody. And that should make sense about where you need to turn to. But essentially, remember betamethasone, go to your MIMS and find a formulation that's fit for purpose for what you want to do. Be that an ointment, a suspension that you repurpose into a rinse, a betamethasone Beclate inhaler, for instance, a nasal spray. The options are legio, but it depends on the distribution and the accessibility of the disease, which one you're going to choose. And the intensity and the severity of the disease determines the frequency of use.
Okay. Then there's a question also from an anonymous attendee that wants to know if you find that menopausal women presents with oral lichen planus more frequently.
So that fits within the age distribution that I mentioned, between the ages of 40 and 60 years of age. But yeah, I'm not sure whether I should weigh in any further than that. I think that sufficiently covers it, because I'm not going to extrapolate any mechanistic explanation for why that occurs around menopause.
Okay. Then Dalmatio is asking regarding recurrent Aphthous ulcer. I have a patient complaining of recurrent attack of ulcer 2 to 3 times a month, which lasts for a few days or weeks. How do you advise them, or what treatment can you recommend?
So that starts to sound a little bit like a complex disease presentation. In other words, you have frequent recurrences. So I would start to look at an underlying reason for why the patient has these frequent recurrences. So you can do a blood panel, a full blood count, and look for the markers of nutritional deficiency, specifically vitamin B12, iron, and folate, just as a starting point of establishing why this could be. We saw a couple of patients experiencing complex presentations of the disease that had an iron deficiency, who had Helicobacter pylori infection, that one patient with HIV that I showed earlier as well. So now turn your attention to the reason, but there are patients in which we will fail to identify a reason. And now, because the topical treatment doesn't really stop a new recurrence, and the patients become disheartened by the frequency of recurrences. And yes, every recurrence, hopefully, will be managed because it will be less painful and you will have a shorter duration of an attack. But now is the time that we start to look at steroid-sparing drugs such as colchicine and dapsone. Now, colchicine, it's a weird way in which that works within RAS, but it's the first agent that we turn to because it changes the neutrophil migration towards those ulcers.
Okay. Then we've got a question from Dr. Maureen Kritzinger. What is the systemic steroid treatment type and dosage, and when do I go from topical to systemic treatment? Okay,
so firstly, that algorithm that I'm going to share with you highlights the fact that it's never a choice between topical and systemic therapy. It will always be topical therapy, and then there will be unique instances that you think, wait, this patient really requires systemic therapy to pull them through this relapse of the condition. Say, for instance, we speak argumentatively of oral lichen planus. And then you will just add the systemic treatment upon the topical treatment that you already are using. And as a reference for the systemic treatment that you can use, firstly, the drug of choice is going to be prednisone because it has an intermediate duration of action and moderate potency. And the reference range in which you can prescribe prednisone will be between 0.5 milligrams and 1 milligram per kilogram of body weight. But if I were you, I would rather steer towards the 0.5 milligram per kilogram of body weight. And then for minimal periods, hopefully for less than 7 days, then you won't need to taper, because those short exposures really does wonders of pulling the disease under control. And unnecessarily lengthy exposures that now necessitates tapering, and actually the disease is so much better that topical would have sufficed. I'm not in such big favor of such a strategy. And maybe this patient, after that short administration, disappears and you never hear from them again because that was sufficient to control the disease. Or alternatively, next month they are back and they need another prescription. And then you realize, okay, wait, we can't carry on like this. Maybe we have to start looking at a steroid-sparing drug because the detrimental effects of systemic corticosteroids will just be too harmful. Yeah.
Okay, I see there's a question. Besides Enzycle toothpaste, are there any other brands of toothpaste that don't contain sodium lauryl sulfate?
The ones I know of are Sensodyne Gentle Whitening. That's the multi-care range by Sensodyne that does not contain sodium lauryl sulfate. So just to reiterate that it is not the enemy, it is just irritating to the patient that already experiences mucosal discomfort. So even for the patient with Lichen planus and a geographic tongue, they may experience a burning sensation when using with an SLS containing toothpaste.
I see we've got a question from Johannes Jacobus Spies. Is there any medication alternative for patients allergic to systemic prednisone?
Ach nee, that's terribly difficult. I have had exposures of patients with who was allergic to topical corticosteroids, and there's a very interesting way of picking from a different topical glucocorticosteroid drug class, which doesn't make logical sense. So I would argue that you would probably have, and I'm not sure about how these allergic reactions to prednisone would work, whether an alternative like methylprednisolone or hydrocortisone, or maybe looking at something like betamethasone would actually be able to do the job. But it's very hard to make calculations between these, the low, the moderate, and the high potency drug classes. And within that moderate one, we have prednisone, prednisolone, and methylprednisolone. So going downwards to a hydrocortisone, you will have to multiply the hydrocortisone dose by 5 to reach an equal efficacy. But you encounter much more side effects because of the mineralocorticoid effects of the hydrocortisone. So those are one of the instances in which I would ask an endocrinologist for advice in appropriately selecting an alternative corticosteroid.
Okay. Then I see there's a question again from an anonymous attendee. They say they've got a young 14-year-old female patient that is a chronic cheek biter. It's so severe that she tears the mucosa. She has been treated by a GP with antibiotics as the lesions get septic. And do we need to get some blood work done to establish if there's any other issues at hand besides the psychological component? What would you recommend?
It's a pity that you threw in the psychological component because that was my answer. That maybe you have to address the psychological component first and foremost. Yeah. And as far as using antibiotics to combat a possible bacterial superinfection, I really do think that chlorhexidine will suffice in keeping that surface clean enough, and that antibiotics won't serve the purpose, and maybe you have to think about physical alternatives of keeping the mucosa out of harm's way. I'm not sure, some prosthodontists may have a good idea of a device that can be employed for that purpose.
Okay, there's another question. If the dry mouth or xerostomia associated with nutritional deficiencies, can we prescribe them with vitamin B complex therapy or nicotinamide?
I'm not that sure that xerostomia is associated with nutritional deficiencies. Burning mouth syndrome and recurrent Aphthous stomatitis, that could be associated with nutritional deficiencies, but I'm not convinced about xerostomia per se. But if you have an objective evaluation of a deficiency, then it speaks to reason that it can be supplemented and corrected within your scope of practice, but not necessarily for the purpose of managing a dry mouth.
Okay, we've become quite busy here. See, are you aware of studies dealing with the use of ivermectin in the treatment of mucocutaneous lesions?
No. You know what? I've had a blindfold on during COVID, and I haven't really paid any attention to the random use of drugs. Sorry to state it in such a fashion. I tend to look at the broader evidence base, and I seldom require or have the need for looking at alternatives if what we have works. So it will be difficult for me to defend some exploratory therapy and leave my patient unmanaged with something that I had available. And that is my feeling regarding the use of explorative therapies.
Then we've got a question from Dr. Hitash Bula. Does Parkinson's disease drugs cause xerostomia?
Yes, there's a significant association, but yet again, with both the disease as well as the management thereof. So I think the disease by itself, and it actually also speaks to Burney mouse syndrome because of the limited dopamine expression, that patients can experience Burney mouse syndrome in Parkinson's disease. But we also find that the patients not equally, but possibly, they can actually also experience sialorrhea in Parkinson's because they lose functional capabilities of lip closure and swallowing competency. So it's a little bit hard to weigh in, and for each patient will have to be evaluated separately to determine that significance. But in my experience, I've actually seen more patients struggling with drooling in Parkinson's, but I'm thinking about a number of my own experience.
Then we've got another question from an anonymous attendee that wants to know, does a pyogenic granuloma next to a non-vital tooth need to be surgically removed, or will endo treatment resolve it? And if required, does surgical removal require suturing?
Yeah, I just quickly want to think about the different iterations of this question, because you can have a pyogenic granuloma next to a non-vital tooth, and yet a non-vital tooth is not necessarily responsible for it. It's not the endodontic status, it's rather the surface of the tooth that is responsible for eliciting this effect. And those are the factors that need to be managed. And the surgical resection thereof, whether or not it will require sutures, if it is along the buccal curvature of the tooth, maybe not. But usually these occur interdentally, and you will strip and reflect the interdental papilla, and you will gain access to the alveolar bone crest. And subsequently, you will likely have to place a suture to reapproximate the papilla.
Correct. Thank you. Just a question I've got, Dr. Fourie. I know when our colleagues in private practice that maybe gets exposure to a potentially oral leukoplakic lesion or a potentially malignant lesion, that might be cautious or not in a position to do a surgical incisional biopsy. First of all, maybe if you can just elaborate, in a potentially malignant lesion, will you do excisional or incisional? And if you do proceed to an biopsy, and if not, is there any other tools that they can have and employ other than the Valscope and the Tolidine Blue, which guides us where to do the biopsy, but just as a matter of a screening to see is this a patient they should refer to get further special investigation?
Okay, Suzette, please help me out if I omit any answer to your question. But firstly, the choice is always to perform an incisional biopsy rather than an excisional biopsy, because you are not delivering the final treatment for this patient. If that lesion turns out to be a leukoplakia with severe dysplasia, or maybe even microinvasive squamous cell carcinoma, it will require a wider surgical excision than you had just performed. And it will sometimes be hard to give evidence of where that lesion was situated, especially on a site lateral border of the tongue, floor of the mouth. So you are not, and neither are the two of us, within our scope of practice, allowed to perform the surgical management of malignancies. Now, that being said, now you are nervous about how to go about performing this incisional biopsy. And maybe I shouldn't let my emotions get me in trouble here, but this is my concern about pushing for our students to perform biopsies, because this is now the trickiest scenario that you've encountered ever surgically, and there's the most at stake for this patient. And now this is the first time ever that you want to play around by performing a biopsy, and I don't think it's fair on the patient. At that point in time, if you don't feel confident in doing the procedure yourself, then you should hopefully refer to a periodontist or a maxillofacial and oral surgeon. Yet, if you ask what is available to me before I start to physically cut into the tissues, yet again, there's going to be many different opinions about this. The one possibility is in performing a brush biopsy. But yet, I'm still not in favor of doing that, because you get half a diagnosis. You only get a diagnosis of the cytological atypia, and you don't have an idea architecturally of what is happening. And we don't have the special laboratory computerized DNA analytics to determine what is the true diagnosis of that lesion. So you haven't reached the diagnosis yet. And if you're going to employ any of the other adjuncts, such as Toluidine blue and the Valscope, there are just too many risks for false positives as well as false negatives. The one case that I showed you earlier, in which we performed an incisional biopsy of the floor of the mouth, initially the Toluidine blue missed the leukoplakia. It was only the central area of a little bit of a red spot that was identified. So think about all of the other leukoplakias that would have been missed, and you would say, "Ach nee, wat, it's okay." Both the Valscope and Toluidine blue said there's nothing to worry about, but they aren't the gold standard in making a diagnosis. Only the surgical scalpel biopsies. And that's where I'm going to leave you with my answer on this topic.
I agree completely. Dr. Fourie, tell me, for our colleagues there at home tonight listening, at what point when they present with an oral leukoplakic lesion, that they or potentially malignant, how long, if a white lesion has been present in the mouth, should they proceed with further investigations?
So that diagnostic algorithm said that if you suspect that local frictional irritation is responsible for that lesion, then it means that you have to get rid of that reason. And once you've done that, you can allow 2 weeks. That is the general advice. But realistically, there's also the possibility for it to take slightly longer. I can recall a patient that we had seen privately that it was suspicious of a frictional hyperkeratosis, and we gave it 2 to 3 weeks to heal, and it didn't. And we performed a biopsy, and the findings wasn't keeping simply with a frictional hyperkeratosis. So that is still a possibility that it may take a little bit longer to heal. And the other scenario that raises clinical difficulties with hyperplastic Candida, because that is an important distinction from a leukoplakia. And you can administer systemic antifungal therapy, but it takes weeks for that lesion to heal, even with systemic antifungal therapy. But the moral of the story is that you don't dismiss that patient and wish them well. You call them back and you keep your eye on them. And if that lesion, I would give it a month at most. So between 2 weeks and a month, and you haven't made headway with resolving this lesion whatsoever, refer.
Then I see we also had a little bit earlier question, where do they refer to? I think you already alluded to that.
Okay, yeah, so it's your choice what is available locally in your community, either maxillofacial and oral surgeon or a periodontist that has an interest in oral medicine.
Then we've got a question also from Dalmatios asking, is wearing of dentures causing dry mouth or xerostomia?
I can't mechanistically explain why that would be the case. I can probably rather argue why it would result in some irritation that can promote saliva secretion. Sometimes a local irritant in the mouth results in more saliva production. I'd think that the patient that has a denture and xerostomia probably also has many other different things going on with regards to systemic medications, for instance, that could be more likely the reason for having a dry mouth.
Then there was another question here with regards to patient with xerostomia on synthetic saliva. Can it be used indefinitely?
Well, if they are keen to use it, I can't see why not. But I haven't met any patients that prophetizes the use of the saliva substitutes. They usually don't. Unfortunately, it doesn't replace saliva because you can't have continuous release, continuous administration. So to whatever extent these products can help a patient with xerostomia, by all means, you can carry on and use it indefinitely. There's no other solution. If that works, by all means.
Dr. Fourie, it looks like we've come to the end of all the questions. Seems like it has stabilized, but if I just look at all the questions that we had this evening, I think you really tickled the thought process of our colleagues at home tonight. Thank you for doing that. And it was such a very important topic that you lectured us on. Thank you for all the effort that you put into the preparation of this. It was well thought out, well presented. Thank you so much.
I appreciate the invitation. Thank you all for attending and sticking with us.
So everyone, thank you for joining us tonight. I think it was a successful evening. And I'd like to thank again SADA and our sponsor Colgate for assisting us with our webinars in Oral Health Month. Then I would like to just remind you again of next week's webinar on the 16th of September. It will be Dr. Bradley Bredenkamp, and he will be lecturing us on periodontal plastic surgery, when to do it. So please remember to register in advance. Thank you, Dr. Fourie. Have a lovely evening, and thank you for all the hard work. Okay.
Thank you.
Good evening, everyone. Bye-bye.
Bye, everyone.
Bye-bye.